It's my pleasure today to introduce Allan Clear, who's the director of the New York State Department of Health AIDS Institute's Office of Drug User Health. Allan's worked in the field of drug user health since 1990. He was the executive director of the Lower East Side Harm Reduction Center, one of the first Syringe Exchange programs in New York State, and of the Harm Reduction Coalition, which is the prominent community-based organization which promotes harm reduction as a mode of working with drug users in the United States. Mr. Clear has served on both local and international advisory bodies, including Governor Cuomo's End the Epidemic Task Force in 2015 and the United Nations Civil Society Task Force on Drugs. And I had the privilege of watching a few of your YouTube videos to sort of get a sense of what you're all about, and I'm sure you're all in for a treat this morning. So welcome.
Good morning. I wonder what those videos were.
I won't say.
So thank you for having me. I am the director of the Office of Drug User Health at the State Department of Health AIDS Institute, and this sort of shows where we lie in the structure at the Health Department. And it's a relatively new office, and I'm going to sort of put into context as to why they created this office at all. So, as you can see, we're sort of mid-level, and that makes me a mid-level bureaucrat within the Health Department after many years of working in the non-profit world. But it's an interesting place to be for me because it's aside from the AIDS Institute that they want to address people who use drugs in a comprehensive way, which also gives me interesting access to people higher up in the Department of Health because I end up being the person that by default they sort of talk to around about drugs. And I was thinking about what the whole history of the AIDS Institute in terms of its healthcare, addressing healthcare people who use drugs. It's, as you heard in the introduction, I came out of, I used to run a Syringe Exchange program on the Lower East Side. And before that, I was doing underground needle exchange when it wasn't legal in New York. Well, it wasn't legal in this country. It wasn't legal in New York City for sure. And the AIDS Institute stepped up, and after a couple of years of us doing underground syringe exchange, they began to regulate syringe exchange as an intervention for people who use drugs. And before that, the AIDS Institute had funded primary care at methadone programs, which again it's a form of harm reduction. It's addressing people's health needs without demanding a particular cessation of their drug use or changing necessarily as a proviso of getting care that you change your behavior. So there's a history within the AIDS Institute of providing support for people who use drugs in terms of healthcare. And I think that, and I wasn't privy to these discussions as to why they set up the Office of Drug User Health, but I think it was this acknowledgement that, they've done this, they've taken on working, funding programs for people who use drugs for 27 years or whatever, and they're going to now own it. And there's no other entity sort of stepped up and said it. And what the AIDS Institute did is bring all of these programs. You see here the Syringe Exchange programs, which is 1992, syringe access through pharmacy-based provision, addressing the overdose issue back before we even thought of it as an epidemic. And over the last couple of years, we've been rolling out increasing access to Buprenorphine and then drug user health hubs, which I'll talk about in a minute. But I think like I said, there's this ownership that's taken place. And one of the ways, and I think you are sort of a different audience, perhaps, from some of the audiences I speak to, because I think that when we talk about, and I'm going to maybe put this in the context of the opioid epidemic right now, but in many ways it doesn't matter. If we were here in 1990, we would be talking about HIV, and people who use drugs, people who injected drugs were the epicenter of the HIV epidemic in New York City at that time. and you can frame this any way you like. We've got the same when you hear the federal government or you hear the governor or a governor, not our governor, of course, or the mayor. Very often we frame this in terms of what we're going to do about this problem. Well, we're going to do more drug treatment, and we're going to talk about recovery and move people into recovery and re-socialization, or we're going to invest in law enforcement, or we're going to look at prevention, and prevention, in terms of keeping people away from drugs ever to begin with. And yet the community that is dying of drug overdoses or is getting infected with hepatitis C or has been living with AIDS are the people who use drugs. And we barely have a name for that. And if you don't really have a name for it, you don't invest in it. So we invest in drug treatment, we invest in law enforcement and ways to address it through arrest or imprisonment, or now a kinder, gentler approach, or we invest in school-based prevention, or we invest in setting up prescription drug monitoring programs and limiting prescribers. But we never actually say, let's invest in this community where the problem actually is. And I think that's a deficit in terms of how do you address a problem if you don't actually name the population you're working with and you don't put real resources into it. And at the same time, you look at what happened with Syringe Exchange back in the early 90s. And we had a fully fledged HIV epidemic amongst people who use drugs, despite the fact we had methadone programs. We had the 40,000 methadone slots in New York City at that time. So the two things that impacted the change in the course of the HIV epidemic were people changing their behaviors and then people dying. Because you went from having just about 50% of all people with AIDS or being people who injected drugs to now it's 2% per year of HIV transmissions from drug user to drug user in New York State. And even that, I think, is probably an overestimate at this point. And it's not because Syringe Exchange is so wonderful. It's because people who use drugs showed up to these programs. And if you're old enough to remember back to those debates and dialogues at that time, it was, sharing injection equipment is a ritual. It's a bonding mechanism. People aren't going to change their behavior. But when you set up a program that's especially designed for people who use drugs, and you meet people in a compassionate and thoughtful way without judgment and without stigma, people respond to that. And people showed up. The Syringe Exchange programs had limited hours back in the early 90s. We had 3 hours on Wednesday and 3 hours on Saturday, and people made those times. And you saw that same discussion around ARVs when they came along. The drug users wouldn't be able to take them, wouldn't be able to get on ARVs, and wouldn't be able to maintain. And then you look at, we have on here the Opioid Overdose Prevention Program started in 2006, but that came out of the community also. And the notion was that the 60% of people who used heroin had been on the scene of a drug overdose. And what you want to do is put a tool to remedy that overdose into the hands of the people who are right there, right then. And that's where we came up with naloxone programs in this country. And the idea was to put naloxone into the hands of people who were there, who are drug users. And so again, you have this the dialogue that drug users are incapable, they can't show up, they don't care, they're selfish or whatever. But in fact, it was drug users who were willing to carry naloxone, reverse an overdose that was right in front of them. And naloxone, as you guys probably all know, is a very easy drug to use, and it's very dramatic in its impact. So what we have there is at least two instances of where if you give a certain amount of control or autonomy to people who use drugs, they can actually rise to the occasion and respond to that. And what we've done over the last 40-odd years is stigmatize drug use to such an extent that we've infantilized people, they're incapable, they can't show up, they need to be told what to do. And some of that is true, but you cannot apply that to every single person that we face who either use drugs or have a dependency. So I'm just going to look at, this is that's what the opioid overdose, death from opioid overdose looks like in New York State. So you can see it got progressively worse over the last, that goes up to 2014. We don't actually have the 2016 figures in yet, but it's not going to go down at this point. And you see the hot spots of Long Island, and places like Sullivan County and Buffalo, and New York City, of course. And I'm just going to talk about Syringe Exchange, not just for 1 second, because I'm going to switch into talking about health hubs. So Syringe Exchange has been around since 1992, and the Syringe Exchange is, we tend to, people like me, use it as shorthand when we talk about Syringe Exchange, and people who are not familiar with Syringe Exchange hear Syringe Exchange. And a Syringe Exchange is you give someone a syringe, they give you one back. And it's actually what it is, a multi-service agency for people who use drugs. And one component of it is the piece where you come in and get syringes. And, the syringes are a very necessary mechanism for getting drugs into one's body. But once you have someone in there that has come in to pick up syringes, they have many, many other needs, and they've walked into a space, they've met a provider that is willing to listen to what they have on hand. Even those, there's a lot of underground syringe exchange programs in the country, and you can have a small rural program, and as soon as you hand someone a syringe, someone will say, where can I get some food? Do you know where I can get some drug treatment? Can you help me out? Instantly, you're dealing with like referrals and then becoming a social worker, and you're dealing with counseling. You cannot avoid it. So when we say Syringe Exchange, we're really talking about, in most cases, a multi-service agency where you provide a lot of services and support for people who use drugs. And I think, and I'm going to get into this a little bit with the hubs, the thing that people most want or need perhaps is connection. A connection without necessarily requirements as well. So if you know you are in a place and in an environment with someone who's willing to actually listen to what you have to say and actually acknowledge what you're saying might have validity, then that person's going to come back and work with you further and come to you with other things that they might need in the future. And I said a minute ago that you guys might be in a different position, because when I was saying that we look at prevention, we look at treatment, we look at law enforcement, and we don't fund where the problems lie. You guys actually see that all the time. You are the providers that see people who use drugs. You provide that support and care for people within your practices and within the clinics. So that makes you a special group of people. So that drug user health hubs. Right after I started last year at the health department, we got this message, and I go like this. It's like, it comes down from the governor. Chamber wants to know, what are you doing beyond naloxone? And we're like, we're putting out a lot on naloxone, and naloxone's a really very good intervention. But they want to know what we were doing apart from apart from naloxone to address the overdose epidemic. So we conceptualize the idea of health hubs, because I think if you back to my naming things, if you name things, you can actually report on it and fund it. And so we expanded the brief of the Syringe Exchange programs, which is why I put the Syringe Exchange slide in there, to think about ways in which people can connect with folks who use drugs. So looking at individuals that show up in an emergency department who have experienced an overdose, in very many cases there's resistance on the part of the person who ended up in the emergency department. They want to leave. There's also very often a desire to get that person out of the emergency department. And very often people have left emergency departments after experiencing an overdose without some kind of resources. And I work for the State Department of Health and New York City Department of Health and Mental Hygiene. We're very interconnected at least with our ideas, and we meet all the time. So there's a lot of activity going on for New York City Department of Health and Mental Hygiene around hospitals and emergency departments as well. I don't know how connected that is to Mount Sinai, but I'm sure there are somewhere. So the idea around the health hubs was to connect to people in settings where they wouldn't necessarily get connected, and to connect them to a provider who was willing to hear what they had to say. If they wanted more naloxone, they get more naloxone. If they wanted syringes, they got syringes. If they want to be left alone, they get left alone, but maybe you can check in with us. You want buprenorphine, we'll get you buprenorphine. So that was the idea behind doing this. And these are a new set of slides, and I wish I'd used my old ones. So law enforcement's another venue by which someone was saying the other day they didn't believe that law enforcement would actually respond positively to referring people to health hubs. But you see it on Staten Island. I mean, that's a good example. You see it in Albany right now as well, where you have some diversion programs that are out there. So on Staten Island, it's called HOPE, which is the Mike McMahon's program, the DA out there put together this program. So low-level offenses, desk appearance tickets, folks get referred to community health action on Staten Island, and they have to show up and be meaningfully engaged, which from the DA's perspective includes harm reduction, includes drug treatment. You also see in Albany pre-arrest diversion programs where Albany PD are sending people to our health hub up in Albany. And so those are folks who are, frequent flyers in the jail system up in Albany who are now just being sent to social services rather than being arrested. But I think what's interesting in both Staten Island and Albany, and we see the same thing in Buffalo, is that law enforcement are also sending people over or taking people over who are actually not arrestable. They haven't done anything wrong apart from the fact they seem to have some kind of drug or alcohol problem, and they're being taken over. Which is a bit of a sea change in terms of relationship between community and law enforcement as well. I'm optimistic in this way, and I think it's a long way to go. But law enforcement, we've trained, that's going to be on another slide, but we've trained law enforcement to deliver the naloxone. Outside of New York City, law enforcement are very often the first responders along with fire department, and they're reversing an enormous amount of overdoses outside of New York City. And we've been doing some interviews with law enforcement, and I asked, it's a big I asked our person who was doing the interviews, what do you see? She said, you see compassion with a whole bunch of people and the opposite of compassion from another bunch of law enforcement. And the ones that are compassionate, the thing they have in common is they know family members or friends who have experienced drug problems. So you begin to see this reshaping and shifting of the way law enforcement plays out with an overdose. So, I tend to, what we're sort of getting, we're getting to some kind of, one of the bigger changes, I think, in terms of what we're looking at in terms of providing medical services and healthcare services, aside from we do things like safety planning. If you've experienced an overdose, how can you prevent doing it again? Talking about injection techniques, talking about fentanyl, for example, as well. But giving access to buprenorphine, low, easy access buprenorphine, and citing buprenorphine in places where you wouldn't traditionally find buprenorphine. So the Syringe Exchange programs, which are the health hubs, have been moving forward with getting buprenorphine into the exchange programs. Hepatitis C is now curable, finding ways in which we can get people started on hepatitis C treatment, and then some pretty basic general medical care, such as abscess and wound care and things like that. But building a relationship between people who provide medical services so they can be bridged into other further medical services. And again, it's like Buffalo, I think, is a good example of this. Buffalo is seems to me, a very tough city to be working in some ways. It's probably got, outside of New York City, it's got the worst overdose epidemic in terms of fatalities and instances, I guess. But it's also got the the Buffalo PD some of them won't even carry naloxone because they'd rather people died. But they're making inroads into breaking some of this down. The folks that we've been funding have been going out and doing lots of conversation, and now they're moving Buffalo PD. And the Erie County Health Department has really been dynamic in terms of trying to change the face of the opioid epidemic in Buffalo. You know what I did? I didn't take those slides out. That's what I did. It's a spoiled PowerPoint. So we'll skip through these. But the one thing that the hubs provide is like a stigma-free environment that people can experience these services. And then these are where the hubs are. There's now 11 of them. Then we started off with 3. Then we added Staten Island, and then we've got the rest. Most of them are just starting up. So the one in this neighborhood is New York Harm Reduction Educators. But buprenorphine, I started talking about buprenorphine before, and I just want to give an example of where I feel like we've begun to have an impact. It is in Ithaca, where the program we found there, that we were hearing that people, if you were in Ithaca or Tompkins County, and you were, I'm hearing this from the Syringe Exchange program, they could not find providers to prescribe bupe. And all the practitioners in Tompkins County, their caseloads were full. And the people who had been to these programs would complain about what they were expected to go through in terms of getting care and treatment for their opioid use disorder. So we funded the program up there. They chose to hire a doctor to prescribe bupe. It's an experienced provider, and she's the assistant director of the emergency department at Cayuga Hospital in Ithaca. So she was hired as 5 hours a week. In 15 hours, she filled her 30 slots. She's now gone to 100, and she's gone up to 70. They immediately went to a 70-person waiting list as well, which if you think in a small college town like Ithaca, if you get 70 people or 100 people on buprenorphine, that completely transforms what you'd expect to see in terms of overdose fatalities in that region, in that county. And our approach to it, and it's we partner with the Office of Alcohol and Substance Abuse Services, and we have slightly different trajectories in the way we think about this. From our perspective, buprenorphine is an overdose prevention strategy. It will keep you alive. You're using, especially in the heroin economy right now, there's fentanyl, it's fentanyl. When you buy heroin, you're often just buying fentanyl. When you get to Buffalo, it's only fentanyl. You don't know what you're getting, and many drug users are actually surprised to find out when you test the heroin that it actually is fentanyl, and they're like, "Well, I've been using that." They're like, yeah, but the thing that people, and you obviously build a tolerance for fentanyl, and you can, so it's not always immediately deadly, but the fact that the shift in strength from one batch to the next is what gets people. So the presence of fentanyl is another game changer. But what we're promoting is buprenorphine for relief for people, so they can. I mean, you think about it. Those folks that they got 30 people in that Syringe Exchange program on buprenorphine, and then you had 70 people on the waiting list. Those 70 people wanted to change what they were doing around their opioid use. They wanted to change, and there was no one there to help them. And the program had to say, go out and buy heroin on the street, and good luck if you survive. And I think that kind of approach is, I mean, it's hard on, it's deadly on people who use drugs to send people out there to do that. It's really hard on the provider when they know they have some solutions or a solution on hand that would help people stabilize their lives. But for a society, I don't know that, I mean, that's not a particularly humane way of treating any class of citizen, is just say, good luck, take your chance. But the approach it's really this middle column, improving patients' general health and well-being. So to stabilize someone on buprenorphine or give people buprenorphine, and I think we can just say to people, you want to try this? You want to take a break? Someone's experienced an overdose. Have it on hand. You don't want to go out there and use today? Try it. And I think that what people find is they try it, And they use, and they try it, and they use, and at some point it's like, you know what, this is better than what I was doing. And you move people along this continuum. Well, they move themselves along the continuum. They experience it, they experience a sense of relief, they don't have to do the same things. Then there's the whole thing about kicking people off of buprenorphine because they smoke weed or they use other drugs. Again, you're exposing people to the black market if you kick people off of buprenorphine. Use buprenorphine, use what people are experiencing as a tool to dialogue around this and see if it works for them, if it doesn't work for them, and what you can do to further benefit them in terms of experiences. And the rather obvious thing that happened at this program up in Ithaca that I'm talking about is even with the 30 people they immediately got onto Bupe. Well, actually, let's talk about the good bit. They immediately... I talked about the difference between OASIS approach and ours. OASIS, or the standard approach is you need to provide all their psychosocial support, because if you don't provide that, you're not really providing medication-assisted treatment, you're providing medication. And some people are quite resistant to being told to go to groups as part of their regimen. But if you give people buprenorphine and you have a structure by which they can engage in other things, they all do. Because I went back to the programs in Syracuse, it's the same thing. People started going back to work. They went back to their former employers. They got jobs. They started running resumes. They went back to school. They started their own support groups up at this program in Ithaca. They went on the radio. They went camping. Which is probably not in the list of menu items that most providers give to people when you go and we're going to go camping next week. But that's what people chose to do. And they engaged back in, you would talk about resocialization or recovery, that was their experience. They actually started a recovery group too, because going to like a 12-step meeting or something like that and being on Bupe, it's sort of frowned upon. So they began to assess what it meant to be on Bupe in recovery at the Syringe Exchange program and how they could, manage that. And so you see all these positive results. So it's like if you trust the fact that people will do it, they very often will benefit from it. And I know there's a lot of fear around diversion. And we have a lady at the hand with the hand up.
Yeah, on that topic, is there any initiative from your office in using like the prior authorization requirements for buprenorphine and things like that? Because I often have to recertify the PA for my buprenorphine patients. It's like, are you in treatment? I'm like, no, you've no show to your social work appointments, but you're living your life and you're doing a really good job. So can I check that box? Yes, and what do we do about that? And I think that is a huge logistical barrier to use medication.
Yeah, I think we looked at the barriers, and I didn't put that slide in here. And the barrier, you're probably all familiar with the barriers in terms of both what you face in terms of a provider and also the barriers that patients have to go through as well in terms to get Bupe. So our buprenorphine initiative, and people can join in and ask questions. I don't care about the slides, to be honest. I just use them as a measure to talk through. And we've already reached 8:30, so I'm totally happy to take questions and things and have a conversation, because that's what this is all about, really. But our initiative is really not several-fold. We're doing, provider trainings all over the state, trying to provide buprenorphine in places where, more rural parts of New York State. And that part of my state job is obviously I don't do that much in New York City. We do, but we don't. We mostly concentrate upstate. And I've learned lots of counties I'd never heard of before. But getting buprenorphine providers into those places. And so part of what our role is, as we see it, is trying to break down some of those barriers and trying to have conversations, with folks or with systems, so we can sort of break down some of those barriers. And what was the question? Because I might not know the answer to that, not being the expert on it.
For many of the insurances, including, I think some of the New York State Medicaid insurances have liberalized this a little bit, but requires a prior authorization to even start buprenorphine. So someone comes in actively withdrawing, and I'm like, in 72 hours you can have this drug, and then also, so they're like, come in trying to start, and we can't start it that day, or recertifying them with the every 3 or 6 month prior authorization requires that I testify that they are in treatment, drug treatment program. So, like, what does that mean? And also, like, if they're coming to see me but not going to see the social worker, going to a group, can I legally and ethically check that box and still get them their medication, which I want to do, but, how do we manage those things, and why is that even part of the prior authorization? Like, we just get rid of the prior authorization in general would be ideal. But,
are you going to answer that?
Yeah.
Yeah, I think there's, if you use, at our institution, if you use the Suboxone Buprenorphine Smart Set form, that meets the criteria for substance abuse counseling, right? So you can ethically and honestly, if you've gone through the different checkboxes and lists in that form, if you do that, then you have documented that you are doing substance abuse counseling without the patient ever going to a social worker or a meeting or anything else, all right? And that's something that's been confirmed by Dr. Herron, who is our chair of mental health. So that you can feel comfortable as far as that's concerned. Getting the prior authorization is something which we can try and get automated. Certainly, where I practice at the Institute, I've got that, so I just hand it to a nurse, and she takes care of it.
Sure. I mean, I guess my preference would be someone who is active on the state level to work to not have it be a prior authorization at all.
Yeah.
I think that, I know the systems to how to get it there, but I think, really we should try to work to reduce that barrier.
Right. So, but we have set up systems to be able to address those issues until the state or the country catches up. But I have a question.
But I can go back and report there was an extremely hostile audience. It was demanded that I take on pre-authorization, and oh my God, and I said, I will. So yes, that's the type of thing we want to address. And I know Oasis is really on board with things like this as well.
Yeah, well, I have a question. Do you want me to repeat the answer that I said for the people? No. Okay. All right. My question, and that's something that we're addressing here, even though I think we're very, very much at the forefront of providing buprenorphine at our different residency programs. We still here in this group at the Institute have a tremendous amount of resistance from our physicians, even physicians who have gotten certified to actually provide buprenorphine, and and I'm personally at a loss at finding how we can get past that point, even after we have people who have gotten training and certification to actually start prescribing. And I'm wondering if you have any experience in trying to get past that point of emotional resistance.
I think, one of the things we have been trying to set up is, there are existing echo clinics, but also trying to set up some kind of system of mentoring after we do waiver training, so that connecting providers with other providers who have experience in buprenorphine and helping people through that fear. A lot of people seem to wonder if they're doing it correctly. Are they doing it right? And trying to reassure people that they are. So we are trying to set up those mentoring type things, which I think that maybe within your own system, that could be something you could do internally, in linking people who have higher patient loads than the folks that only want to keep their patient loads really small when it comes to buprenorphine. Now, we were talking earlier that one of the barriers, we see it a lot with people coming to us and saying, I can't get anyone to bupe. Everyone around us they're at their limit. But they're not at their limit. They're at their own personal limit, which is very often too between 3 and 10 patients. And it's the fear of becoming the druggy doctor and having difficult, complicated patients come in and ruin your very nice practice or make things more difficult for the provider, I think. I certainly don't have the answer to this. I think it's a bad answer in some ways, in that, like, I think things are changing. The more providers we have, the more experience we have within the medical community as to what works and what doesn't work and how to overcome some of those barriers. But I think that very often that you do experience a higher level of need in patients who have opioid use disorder. And that's what that fear is, that experience of dealing with someone you've been prescribing benzos to, and now you realize they have an opioid use disorder, and now you're going to give them buprenorphine, and you're going to cut them off of benzos. How long do you keep them on buprenorphine? Should you cut them off because you know they're using coke every so often, and they're smoking weed as well, and is that helpful? I don't know. Weed is marijuana, it's medical marijuana. Is that good? And it's sort of those complicated thoughts that go through people's minds. And then you have a patient who is a little bit difficult. But then there's the satisfaction of working with changing. This is a medication that completely transforms someone's life. And I think there are other medications probably like that, but maybe none perhaps as dramatic as buprenorphine that we have available to us for people who are experiencing real struggles in their lives, and you can turn it around within a very short space of time. I don't think that answers your question, but I think raising the question of how do you get more people to prescribe more, I think it's a case of everyone pushing people further and further and having these conversations. Why do you only have 7 patients in your practice? Take it to 12. That's another 5 people's lives you change. If you have enough people, you begin to move it forward. But I don't know, was that unsatisfactory? Yes, it was unsatisfactory. But we can come back to that.
Is this on? Yes? Thank you for coming and bringing this to our attention. I think the answer to Joe's question, this is a clinical leadership issue. Mm-hmm. And listening to your presentation, I mean, one thought comes to mind, which is you could think of diabetics as having a sugar use disorder. And even though sugar is not illegal, the fact is part of our job is to take people who can't control their use of sugar and working with them. And there's a few medications that are really helpful. And some diabetics are really hard to manage, and they're fall off their diet and they don't do what they're supposed to. But that's really what people in primary care are supposed to do. Like, we take people from where they're at, and I think the fact that you have fairly qualified health centers up there, and we're a network, we should be the first responders to this. Mm-hmm. And I think it's, Joe, you're such a good example of what's supposed to happen. And it's really, rather than getting people to do this and sort of forcing them to do this, to frame this in, this is our public health crisis, and as public health providers, this is what we're supposed to do. And so rather than say that, we've sort of made this decision in our organization that everybody is getting trained to do this, the next step is to get everybody to feel comfortable to do this. And I think that is an opportunity for us to show how you actually accomplish that, and getting our residents in particular to realize this is part of being a good family physician for the rest of your career. So, I think if we, and we'd be particularly interested in sort of hearing more about these hubs and how, especially fairly qualified health centers, which also sort of function as community hubs, to be able to make some of these community connections, to be able to build on this, and to have some successful role models or examples in the community of what works and doesn't work.
Yeah, and I think you're right in terms of I'm not a doctor, so I don't have that. I can't whip you with those credentials, and I don't have value in that way. And I think that the call, I don't know if that works either, in terms of the call to we have a serious problem. This is probably, for me anyway, and anyone maybe my age, it's like we had the AIDS epidemic when everyone died. We have an opioid epidemic which feels exactly the same way. And the solution does lie in here. There are many things we can do. But there needs to be this leadership from the healthcare system and physicians and PAs and MPs, and to create an environment. I mean, we would look at what keeps people out of care, and very often it's stigma. It's stigma in terms of, and it's very people use drugs are not idiots. When they go in and they tell you a story or tell someone a story, it's because they go in expecting not to get the care that they deserve. So they will make up a story to make you think that they deserve to get what they're going to get, instead of being upfront and saying, this is what I need, and the provider, the physician or whoever, saying, this is what I'm going to give you. And that stigma and that the fact that someone is criminalized for their behavior, and be stigmatized for that, and being beaten over the head all of the time, and feel a great deal of shame about who they are and what they've done, and are told all the time, look at the damage you are doing everywhere, to your family, to yourself, everyone. Those are all barriers that this person comes in to see you face, and then they do face discrimination very often. So it takes extra effort in some ways on the part of you guys and the community in the clinics to create an environment that makes it safe for people to go in there. And when we talk about the reason why the health hubs were sort of designed as points of connection for people who use drugs is because they had a history of being a stigma-free, theoretically, environment where someone was going to go in and understand who they are when they came in. And I see two aspects to what we do around this in the Office of Drug User Health. I sometimes say health department, and I have no authority to do that. But in my worldview and the worldview of the people I work with, it's that we're doing two things at the same time. We want people to access quality healthcare through FQHCs and healthcare settings. We want people to get that. We want people to be able to be safe to go into a place to get their needs met. At the same time, we realize that doesn't happen for so many people, that we're basically creating an alternative reality so that people can get those needs met. So you got two things going on at the same time, is creating an alternative, not quite an alternative medical system, but creating an alternative care system, which we've got 11 places where this is happening, which is not a great deal. At the same time, we need to figure out how we undo the settings where people can go to get health care, which is part of, and I think maybe it's different in New York City, I don't know. But but that's what we're trying to do. It's like we actually have this capacity building anti-stigma program, which Jeff Weiss, do people know Jeff Weiss? He's in this building somewhere. He's at Mount Sinai, and he has a program. He's magnificent. He's got a beautiful program. It's a model program. But we have this anti-stigma project going on. It's a pilot, really. We've got 12 programs from around the state looking at what programs can do, and that includes Mount Sinai, because Jeff is there, to make the environment better and healthier for the people who use drugs when they come into it. Things that go on the wall, but just the way we address people and try to meet their needs. So that's sort of what I see our task as. I mean, and the complicated thing is how do you provide even basic medical care in non-Article 28 settings? That's a whole horrible problematic maze to wiggle through, which we're trying to work on too.
I had a question.
Oh, there you go. Sorry.
I get to talk. I want to go back to Joe's question about the barriers for us to provide this care. And I was thinking that many of our residents see these folks in the hospital when, forgive the expression, they're already kind of train wrecks. Mm-hmm. And they work very, very hard to tune them up again and send them out, and then they come right back again. And there's, I think, often a feeling of hopelessness about working with people who have drug addiction problems. And it occurred to me that the word you used today that I almost never hear around this problem is the word transformative, and that there really are stories out there, as you started to say, about people who have transformed their lives as a result of our interventions, and, of course, as a result of their own very hard work. And I'm wondering how to get those stories out there, because we don't hear those stories very much.
I don't know. I mean, I think that, I think within Mount Sinai, I'm sure there must be physicians' letters. There's the whole addiction, ASAMs and NISAMs, and that's addiction medicine. But someone within this institution, there are publications, aren't there? I don't know, but to produce some of those stories yourselves, because your own providers have these stories. You guys have these stories. We actually just did it within the DOH. We had a Syringe Exchange meeting, and it was the 25th anniversary of Syringe Exchange in New York State. And instead of recognizing the programs, I recognized the work that people did, and we had people who had used the programs as drug injectors tell their stories. And those stories got written up by someone at the Department of Health, and that will get circulated. I don't think it's gone out, but it's that kind of thing. I used to work for the Harm Reduction Coalition, and when we used to do provider trainings around, I think it was around overdose, it may have been around buprenorphine. We had, actually, even now, I forget. When we do our waiver trainings, we often have someone who is on buprenorphine to talk about what that experience has been for them. And I know Sharon Stancliffe, who's consultant to the AIDS Institute and a buprenorphine provider, talks about how being a bupe provider is so satisfying, or an addiction doctor is so satisfying too. So it's I guess it goes back to what you were saying, this clinical leadership is to highlight those stories. And also, at the same time, highlight the problems as well. That what are the questions that people have, and how will they resolve? Because that's that inter-networking that will transform practice as well, I think. And I put my address up there so that all of these questions around pre-approval and anything else, just email them to me, and I can either give answers, I can connect people to things, and you can give me marching orders as to what we do next. Then I delegate it.
So I just have a very specific question. Could you talk about what you actually say as part of your counseling to people around preventing accidental overdose? Like, what are some of the things that people can do? Because, as you said, so many people, they're injecting things, they have no idea what's in it. Are there specific things that you tell people about what to do around that?
I think there are specific things. I mean, it's an approach is to look upon the people that we're talking to as experts in what they do, and to discover what it is that they actually try to do to protect themselves and the people they use with. And it used to be, we used to tell people, have a regular dealer, have house dealers and things that you would go to, so you knew what their product was like, and now we can't even say that. But there's a number of things, I think. One is about doing tester shots, testing your drugs that you've got, even though you got it from the same place as you got yesterday. If you want either a tester shot or inject more slowly if you're injecting, so that people can feel the strength of it before injecting the full shot. And to hold on to it. If they feel this is going to be a strong shot, it's a benefit. you've just saved some money, and you can save your shot, and you've got it for later as well. So there's tester shots. There's the using in sequence as opposed to we're all going to use it at the same time. It's like make sure that someone is sober enough, essentially, to administer naloxone if someone falls out. I think it's about creating a consciousness around what someone does in every step of their practice, where you buy, how you mix up, how you use it. Crowdsource what you know about a certain batch of drugs and what it tastes like and looks like. And the problem with that, again, is we actually did survey. We surveyed drug users all over the state, and someone would say, well, I know it's got fentanyl in it because it's blue, or it tastes like this. And then someone would say it's orange, tastes like this. And there was no, someone said it's sweet, someone said it's sour. There was no fixed thing. And we just realized that we haven't reached a state in the drug economy where we can say by looking at something, it is what it is. But I don't know if you've heard of the fentanyl testing strips that people have been using. So that it's for urinalysis. Like when you've got these little strips and, you test someone's pee and it's got fentanyl. It tells you yes or no, fentanyl present or not. Well, the community has taken it, instead of using it on pee, they're using it on residue. So you mix up your shot and there's a tiny bit of residue, because these strips are very, very sensitive. And so you mix up, you squirt some water into the cooker, there's a little bit of residue in there, and you stick the fentanyl strip in, and it's a bit like a pregnancy test. It tells you if fentanyl is present or not. And people go, wow, I didn't know. And suddenly they've shifted from, doesn't seem to affect me or impact me to, so this is me. And that shift in consciousness changes a little bit about the way people use drugs. I tell you,
this is the stuff that nobody knows, and just to get back to Red's point, part of this is about confidence. And as you want to take care of folks, you want to be able to do this kind of counseling, and you want to be able to give people this information so that they don't kill themselves while they're doing it. And yet I think there's still that culture of, do I really want to be counseling somebody about how to shoot up their drugs? I think that's sort of out there in the general kind of sense. So
yeah, I think the answer is yes, you do.
You do.
I mean, these are people doing medical procedures on themselves, and you guys have some expertise. And but when we provide a shot in a medical setting, it's like we use two hands, and a drug user does it with one hand, sometimes does it with the hand that they're not very good at. If you're right-handed, you can do it left-handed. And these are quite complicated procedures, and people practice and use them. And I think it's very difficult for anyone who has a set of trained expertise to get into a position of saying, I don't know. So I used to think that about HIV counseling. People would say, all right, what's your risk? Oh, sex, I can tell you put on a condom. But they were really reluctant to talk about drug use because they didn't feel like they were experts in it. And the solution is to ask the person in front of you. And I think you've got this dynamic, this potential dynamic here, that you do have a level of expertise that you can transfer to that person. But you also need to listen to what the person is saying in front of you. Some of it is, and of course, you don't have half an hour to sit down necessarily with a patient, but finding out how they feel when they go out and use drugs. What is it? Are they afraid? Because there's that myth, remember? There's another aspect to this. It's like, you tell people if the drugs are strong, people are going to rush out and buy it. Well, in this era, people are saying, I am scared. I am scared to go out, and I don't know if the next shot is my last shot. And other people are saying, I love it. I'm going to go and get some. Tell me where it is. And it's like you play with those dynamics and listen to people's fears, but also work with people who are maybe a little bit reckless. With those reckless people say, do you have naloxone on hand? Do you have, is there anyone there going to revive you? What's going to happen? And work through that. But it's like you have an expertise, but they have an expertise too, because they're experts in their own lives, and try and glean it from them and figure out what it might be when you have the next person. And obviously there's so many different stories out there in terms of why people do what they do and how they do what they do, why they do what they do, and how they got on that path. Because I think that I was going to say earlier that when we had the story of the folks that went from 30 people on Bupe in the Syringe Exchange program, the outcome of that was, aside from all these wonderful things that happened, was it was a burden on the program, because suddenly these people were asking for all these other things. They weren't going out necessarily and buying drugs. They were looking at other medical conditions. They were looking at their social conditions. They were looking at their marriages. They were doing, looking at relationships with people. And the program was like, now we're overwhelmed with all these other needs. So, and that's a beautiful thing. It's a struggle, but it's a beautiful thing.
Could you talk about how you would envision FQHCs working with the hubs more closely? Like what could those look like?
I think there'd be bi-directional things that go on. That there are things that a Syringe Exchange program might want to do with someone that an FQHC might not want to do, and vice versa. The FQHCs have the resources. Create those links. Create that real human. That actually the example in Buffalo, and these are early days, I think, in transforming things. But so much work happens in emergency departments. But the hub in Buffalo, the emergency department at ECMC, Erie County Medical Center, which is where you see whatever it is, 10 overdoses a day show up. The medical director there, Josh Lynch, is calling the personal phone of the person at the hub saying, I'm sending someone over right now. And she said, it's amazing, they all come. And then she hooks them up with something else. And I think that could be the relationship between the FQHC and the hubs as they set up. But we're at 9 o'clock.
I don't think there's anyone posted in here immediately after. If there are more questions.
Yeah, we do more questions. We can end. We can do more questions. I'm dressed like this. Anyone who knows me, I don't normally dress like this, and I didn't dress for your benefit. I have a work thing at 10 o'clock.
Well, maybe we can end it if people have questions. They can come down.
Yeah.
Thank you very much.
Yeah. Thank you.